our team was reflecting that we're in the third year of the pandemic, and healthcare has obviously been at the center of it. And we've also seen a lot of healthcare organizations innovate, pivot. We've seen telehealth become more prominent. We've seen data collection increase. And so we started asking ourselves and taking a step back and trying to see, is the progress that we're making actually advancing health equity specifically for the safety net population? Have we made care more or less accessible to those that we are trying to serve?
Welcome to the Health Pilots podcast, presented by the Center for Care Innovations. This podcast is about strengthening the health and well-being of historically underinvested communities. Every episode offers new ideas and practical advice that you can apply today. This episode is adapted from a recent webinar. Enjoy.
I would love to start with introductions. If we can each go around, share our names, our organizations, and the roles. And I'm happy to kick it off. As you said, my name is Eric Lamb. I'm with the XCG team, where we partner with social impact organizations like the amazing ones that you see here today to design and build tech that improves lives. I'm one of the partners, and I lead our health work, which includes supporting community health centers and making their services more accessible, as well as making direct services like affordable housing more accessible with our Bloom work and so forth. So happy to dive in there. Super excited for this conversation. Sophie, would you like to go next? And then maybe we can pass it to Sylvia and Mike afterward.
Happy to. And thank you, Eric, for bringing us together here for the conversation today. I'm Sophie Bergqvist. I'm president at Center for Care Innovations. And we have a vision that everyone has fair, just, and inclusive opportunities to be healthy, which is a definition of health equity. And therefore, I'm very happy to have the conversation here today. And what we do is that we spark, seed, and spread innovations to improve health and well-being among historically underinvested communities. Everything we do is in partnership with everyone on this call and many of the people in the audience. So we're happy to foster those partnerships further. And I hand it over to Sylvia.
Yes, good morning, everybody. My name is Sylvia Hassai. I am the Director of Development and Communications at Lifelong Medical Care. We are a federally qualified health center serving 3 counties in the East Bay, Contra Costa, Alameda, and a small part of Marin. And we basically provide high-quality health, mental health, social, and dental services to folks regardless of their ability to pay, their housing status, or immigration status. And we were founded, we really grew out of the civil rights movement, and health equity and health access is really what our main mission is.
Good morning, everyone. My name is Mike Locke. I go by he and him. I'm planning manager at Asian Health Services. Like Lifelong, and great to be here with Lifelong and Sylvia. We're another FQHC, serving Alameda County. Actually, Asian Health Services and Lifelong are 2 of 8 FQHCs serving the great and diverse Alameda County. AHS, we serve over 50,000 patients a year in 14 different languages. And my role at AHS focuses on advocacy and empowerment of our patients and the broader communities that we serve. And that sometimes involves everything from, healthcare reform to language access to hyperlocal, pedestrian safety issues and things of that nature. At AHS, and I could say with a lot of FQHCs, we consider, advocacy just as important as patient care. So look forward to talking with you all.
Thank you for this. So how we actually came about this topic and creating this health equity series is our team was reflecting that we're in the third year of the pandemic, and healthcare has obviously been at the center of it. And we've also seen a lot of healthcare organizations innovate, pivot. We've seen telehealth become more prominent. We've seen data collection increase. And so we started asking ourselves and taking a step back and trying to see, is the progress that we're making actually advancing health equity specifically for the safety net population? Have we made care more or less accessible to those that we are trying to serve? So the first question that I want to kick off for this panel is, what are ways in which advancement in healthcare over the past couple of years has made care more equitable and ways it hasn't? Sophie, I'd love for you to start that conversation.
Thank you, Eric. Yeah, the last 2 years has really been a stress test on all health systems in the world. And in many places, it's put a spotlight on the weaknesses more than anything. I'm from Sweden, and there it's universal health coverage, it's a good healthcare system. But in that case, you see that there's been real weaknesses in care of elderly, and especially immigrant elderly families getting the care that they needed. And here in the US, we have had deep inequities for a long time, and we are not in a better place. We have seen a much larger drop in life expectancy for Black and Hispanic Americans over the last 2 years than compared to white Americans. So I think it's important to recognize that we're not in a better place. We shouldn't frame it as if we are heading in the right direction. This has been 2 years of stress testing and really uncovering the deep, deep issues that we have. But that being said, we also have advancements in certain areas, and it's important to look at those promising practices and pay attention to those and continue to invest in those to improve equity and access to care and ultimately improve equity in outcomes. And one of those indications, I think, is the drop in no-show rates. So people that used to schedule an appointment and then not being able to see their provider for different reasons are now much more likely to attend to the appointment that they have made. And who are behind those drops in no-show rates? There's far more research needed, but we have heard that it relates to people that face transportation challenges, that had work that didn't allow them to see their provider as timely or at all, but also people that are caring for family members, being it children, being it elderly at home. So that drop in no-show rates, I think, is a really telling story. And where does that come from? It is really the increase in modalities that you now can see your provider over video and also call your provider. That is one step towards more patient-centered care that I think we should build on and do far more around.
Yeah, I love the focus on drop in no-show rates and really seeing that as a telling metric. And also agree that I think we do need more research and more investment in the promising practice that we have seen to see what work we're doing and where we are continue to fall short. Because we know that video visits work for some, but they aren't always accessible for everybody. Sylvia, what are you seeing from your end? What has been advancing and or have we been short on?
Well, I will just echo Sophie's where we are short. I think most of us know there are really severe problems in our healthcare system. But to focus on a bright spot, similarly to what's happened, if I may introduce a current event, you hear a lot of news analysis right now about what the war in Ukraine has done for the NATO alliance. For example, this shocking event has galvanized people in a way, in a week that hadn't been able to happen in years. For me, the bright spot was around the care of the unhoused. I think in the years leading up to the pandemic, folks began to realize, or not just realize, but start to implement policies that said, okay, you've got to house people first to help them overcome addiction, to help them get jobs and things like that. The pandemic, because it was a public health crisis and so transmissible, raised not just the need, raised the awareness and the importance of addressing healthcare for the unhoused. It's always been there. I don't want to minimize. It's always been there, but there was a greater effort made to address this issue. And what we saw was more money and more grants aimed specifically at meeting the healthcare needs of the unhoused and the movement of unhoused people into housing through, in California, it was through Project Room Key, which took over a lot of hotels, for example, and just ensured that unhoused folks were separated by, to help reduce transmission and housed. And I think that was a positive in all of this. And I hope that can continue here in California in particular.
Yeah, Sophie, thank you for that example. I know leading up to this, we talked about Project Room Key. I'd love to dive in deeper later on in this conversation too. learn a bit more about that and the intersection between health and a lot of other very needed direct social services. Before diving into that, Mike, I'd love to hear from your end what you've been seeing.
Yeah, and I think it was mentioned before, those are great points made by my colleagues. And Sophie was mentioning about the, reduced in, no-show rates. That's definitely something that we saw because with adding in, telehealth into our services. But a big point I wanted to mention for the audience, if they weren't aware, is that telehealth was not reimbursable under Medicaid and Medicare until the pandemic. It was a special, policy put in. So that was a big sort of game changer, and a big game changer when the pandemic started, where I think a lot of our clinics and other, clinics were almost 100% telehealth for a while in order to, set up the infrastructure, get the PPE needed. There were supply chain issues, and we were collecting donations from nail salons and wherever we could in order to, be able to put up the infrastructure until, we were able to have the testing and all the systems in place. But I'll just mainly add as far as who's being left out is there are tremendous still language barriers that are impacting limited English speaking immigrant communities. I mentioned before AHS, we serve, 14 different languages, and, not a lot of them are provided sort of as far as language access when it comes to a lot of these safety net programs. I believe unemployment, EDD is still only in Chinese and Spanish. But for a lot of that cases, for a lot of other communities we serve, including Vietnamese, Korean, Burmese, Filipino, many more, because those, whether it's been forms or even just flyers, we've sometimes had to, our staff have had to create some of those materials, those translations, just to be able to point folks in the right direction. And oftentimes, our patients, whether, they do come to us for renewal in Medi-Cal and CalFresh and other programs, but they're coming to us for help with how do I fill out unemployment? How do I apply for the rent assistance program? And those are things that a lot of our staff aren't trained for, but the role that FQHCs play, we know that we play a wide range of roles. So, I just say the language barrier is something that still definitely needs to be addressed.
Thanks for highlighting that, Mike. I think something that I'm hearing across what Sophie, Sylvia, and Mike, you mentioned is there are some bright spots, and there has been motivation and spotlight on advances. And at the same time, we still recognize huge areas for improvements, including language barriers. And I think the three of you, as well as a lot of the safety net, see a lot of that firsthand. And so I want to talk a little bit about data and how we are able to communicate what we are seeing in some ways a quantitative way to others who may not be on the front lines as well. We know that tracking data has been more prevalent. Obviously, data on COVID rate deaths, and people are able to see a lot of statistics. But how about data with respect to who is being left out of accessing care in social services and data on health equity itself? And so my next question is, how have data collection and analysis changed during the pandemic, and where is there clear room for improvement? Sylvia, would you like to start with that?
Yeah, and it's an interesting question that clearly even predates the pandemic. And as Mike mentioned, we are serving the same county, and we are 2 of 8 health centers. And so one thing that happened is that as a consortium of health centers, we have worked together more and more to have, data collection systems that are the same, so that as patients sometimes transition between our health centers, we are able to keep them in the system and collect data more smoothly. And one of the things that was fairly interesting for Lifelong situation is that we transitioned to the Epic electronic health record system right before the pandemic hit. In fact, I believe the transition was really happening, was kind of continuing to happen just at that moment. So I joined Lifelong in January of 2020. We were undergoing this transition. And while it was difficult, because any kind of transition to an electronic health record system is difficult, it turned out to be, quite fortuitous in the end partly because of the needs of data collection in the pandemic. So investing, in data collection at sort of the lowest levels of the health system, center level, is the way, and it has to just kind of be that investment from the ground up so that, as a state, as a country, we're collecting data is super important. So that was one of the changes we made that ultimately made both communicating with our patients and also collecting data from them more smooth. There's always a tension between collecting data and serving a patient in the sense that any data collection involves questions and filling out forms and collecting information that not everybody's comfortable giving. And it can be, there's a tension between having it be a barrier to care, but it's also actually something that ultimately can help improve access to care. Just the importance of it, I think, became very clear during the pandemic. In California, for example, what is the data showing us? And we know that the death rate for Latino folks is 15% higher statewide than for their proportion to the population. It is 77% higher for Pacific Islanders. The death rate for Black folks is 17% higher. And for communities with a median income of less than $40,000, the case rate is 24% higher. So we are able to cut data by ways we're used to, by ethnic group or income. We also know that housing density, where there are more folks packed into more places, also led to, higher cases. So all of that was super important during COVID and remains important as we exit COVID to continue to improve our own healthcare systems.
Yeah, Sylvia, something that you said that I want to underscore is you said that one of the efforts that you and Lifelong Medical has been part of is the consortium of health centers. And what I understand that is that when we are looking at the safety net, people transition from one health center to the other. So continuation of that data collection and knowing who that person is critically important, which is, I don't want to say unique, but it is a big factor that we cannot overlook if we really want to be caring holistic for a person.
Yeah. I mean, just from your own personal experience, imagine when you've changed a job or your job has changed their healthcare provider. It's not easy to navigate for anybody. And then you take some of the most vulnerable populations, whether it be, vulnerable. There's so many ways our population is vulnerable, and it's just that much more of a barrier. So the more we can do to help smooth that out, the better.
Yeah, absolutely. Mike, with Asian Health Services, are you also seeing people kind of transitioning into the Asian Health Services and your clinics and transitioning out? What collaborations are you seeing from a data collection perspective with other health centers?
Great question, Eric. And I think is what Sylvia brought up about transitioning to Epic, and all of the 8 health centers on the health consortium were able to transition. And that change to Epic was epic. Sorry, I didn't mean to make a pun there. But among other things, is that being the same health record system that a lot of the local and regional hospitals use. So there being that compatibility and that being able to help, look at the continuum of care. Like you said, if folks went to a different health center or went to a hospital. And just shout out to, my team's information systems and all our clinicians, because not just the transition to Epic, but in COVID, it has been a lot of work, meaning, there are new patient workflows that are being changed weekly, if not multiple times a week, based on schedule changes, trying to figure out billing codes for telemed. Whenever we have a new test site or new vaccination pop up, needing to have things set up for that. And I'll just say is that in strong consultation with other health centers and with the county public health departments, looking at the neighborhoods and zip codes that had the highest case rates and highest hospitalization rates, something AHS has been doing is trying to go out in the community and do mobile vaccination sites in some of those communities. And being able to not just, build and they will come to our clinics. Our clinics are nice, but to have mobile teams to be out in those communities and partner with different community stakeholders, whether it being churches, nonprofits, anybody who will listen, in order to try to reach the communities that have been hard to reach as far as both testing and vaccinations. And the data has been very crucial in being able to help us find, knowing that just going off of testing, it doesn't show the full picture. But being able to, use that data as well as work with, trusted community providers and leaders, figuring out ways to really do some targeted work to reach the hardest to reach.
Absolutely. Sophie, I saw you go off mute. Did you have something to add?
Building on what Mike just said, the opportunities is during the pandemic, the sharing of data, as has been pointed out, it was a necessity for being more targeted with the vaccine outreach. But how can we build on that? Allowing that sharing of data to guide resources across the board in a much more proactive way. So now we have a better sense of who is facing digital barriers, where are the connected homes and which homes are not connected. Because that starts to be almost a social determinant of health. It impacts your education. It impacts your ability to navigate other social services. And there's a lot of resources. FCC and others are working to connect homes. And how can then healthcare be more of an enabler to make those homes connected? So this sharing of data, but also sharing of data to guide resources as a real opportunity. And then we've started to see more and more of these collaborations to use data to guide payments towards value-based care. So that's another opportunity with the data and the data sharing that you can actually, what is the benefit of assuring healthy food? What are the health benefits? And let that then start to build a case to do investments for better access to healthy foods and housing and so forth. And then a third area is it's just much more data. With remote patient monitoring, it's a tsunami of data. And how can we make sure that we are being more ahead of the curve of building capabilities to analyze that data? Because if we don't, those systems will start to build on biases and drive. There's algorithms being developed that are guided based on a population group that is not the communities we serve. So how can we make sure that we are serving historically underinvested communities, making sure that we are on top of building the data analytics capabilities, given the amount of data that is coming our way? So those are three opportunities or challenges that I see.
Yeah, thank you for highlighting those, Sophie. We've touched on a little bit around social determinants of health. And we know when engaging communities that people don't think about healthcare alone. When they think about healthcare, when we interview people, they're talking about housing needs, food security, many other things. And while there's been a lot of talk and some really neat initiatives to push attention on social determinants of health, I'm uniquely curious about the three of your perspective on what has worked on the ground that has led to real change. So if each of you can give an example of a sustainable collaboration across the social safety net. Sophie, did you want to start with that?
There's several. So we work with federally qualified healthcare centers, but also with community-based organizations, and more so with collaborations between the two. Starting off with making sure there's cross-functional teams to build humility and curiosity. So it really starts with that, because very often you bring in community members, but if you are not allowing and being prepared to drastically pivot, when you bring in community members to the table, you're not doing justice to that opportunity. So we often start with just building mindsets for collaborations and teams working with the community around curiosity and humility and supporting leadership to be allowing things to go in the direction they originally didn't intend. And the reason I mention that is because every single successful partnership that we have seen has really been a result of leadership and teams' ability to pivot. They end up doing things they originally didn't intend to do. So one example was CCLAC, Venice Clinic and Food Forward. They went through our Catalyst program, which is capability building for human-centered design. They originally thought about how they could improve just food distribution. And then they did interviews with the community and realized that the food that they were distributing wasn't really helpful for the community. They actually needed prepared food because so many of the people they were serving didn't have an ability to prepare the food that they were giving. So that was the first pivot. But where's the sustainability in that? It was a excess of food to be distributed, but how are they going to sustain this work? So they started to do interviews with health plans. And there was more than one health plan who said, I would be interested in making sure that this continues if you can show me that this is benefiting the health of the community. So this partnership between 3 organizations became a data initiative where they started to collect data on what are the health outcomes. And they're starting to see some very, very promising results that then together with the health plan, they can look at, actually, this is making financial sense for us to bring resources and support this. So this is an example of thinking outside of the box, taking input from the community to make sure that what you offer is actually what that community needs, but then also daring to think outside of the box and speaking to health plans and others to sustain the work. So that's one example.
Awesome. Thank you, Sophie. Mike, is there an example that you've seen from your experience?
Yeah. And, AHS in our almost 50 years existence had, strong, partnerships with, different community-based providers, agencies, and has led a lot of sort of strategic, coalitions, on trying to work on some of these things. And I'll just say is during COVID, making sure that, working with providers to make sure unhoused folks in our communities were getting vaccinated. And, making sure working with some of the affordable housing providers to make sure that folks had access to testing and vaccinations. And, one thing in particular that I'd like to mention is, we heard from one of our community partners, the Asian Pacific Islander Legal Outreach Team, who they were during COVID saying that the managing attorney at the time who works with a lot of child custody cases, and they're saying that at the time during COVID, there needed to be, the judge had ruled that there needed to be clear plans as far as COVID testing when dealing with a shared custody situation. And they had mentioned that, having access to, our COVID test site, and having, pretty quick turnaround time on tests helps make those shared custody situations work. So definitely working in partnership with the other service providers in the area to, during this time, make it work.
Yeah, I love that angle of the partnership as well. It seems like that was an example of where there is a big health initiative that is needed for community benefit. In this case, the vaccine rollout, and that kind of drove some of the partnership, which is in some ways a little different than what Sophie shared, but equally as important. Sylvia, how about from your end? Is there an example that you'd like to highlight?
There's a couple. One was definitely centered around food security, probably something similar to the one that Sophie highlighted. There was before COVID, had been a for-profit catering kitchen that was struggling during the pandemic to figure out what to do. And ultimately, I think at first they sort of just charitably made meals and gave them away, but then they found that there were grants available to do that. And we partnered with them to get some prepared meals to particularly like our senior community, homebound seniors and seniors in general. So that was one partnership. And we did have another partnership with a church in West Oakland, which was a trusted community partner around administering vaccines. And that partnership improved the uptake of vaccines in one of the hardest hit communities in Oakland. And so, those partnerships, those relationships going forward, I'm not personally privy to what's going to happen next, but clearly those relationships changed during the pandemic and can only be a good thing if we're able to work together to do the kinds of things that Sophie talked about. So those were two examples of some new partnerships for Lifelong.
Great. Thanks for highlighting that, Sylvia. I'm recognizing time. I am seeing a couple Q&A come in, and I'd love to jump into those. Okay. So the first one that I'm seeing is someone's asking, how can private sector players, so startups in particular, play a role in addressing some of the gaps you're seeing? How do you approach piloting new innovation?
There's not lack of challenges to work on. So that's the good news. There's a lot of opportunity to improve things. I think many startups are fueled by brilliant minds and hard work, and very often designed for a population where the money is, and not to underestimate what it takes to actually serve the communities we work with. Language was being brought up by Mike. Don't have that as an afterthought, but really lead with it. And engage consumers and users early on to design your solutions. So be committed to it. And if you're committed to it, make sure that you engage with the users and include it in from the get-go in the design. And then it's about partnerships again. I mean, in order to pilot test something, you very often need a partner to pilot test. So how do you establish those relationships? And starting off by understanding the community, understanding Medicaid or Medi-Cal in California, understanding the reimbursements and the bill, how you can make it billable, make it easy for the FQHC. It's some homework to do, but if you do that homework, hey, it's a huge market. So language, understanding the population, and really building the relationships after you've educated yourself on what it takes to be successful. Money speaks, so how to be able to pay for it is a big piece.
I think that what Sophie outlined earlier in the partnership piece is just as applicable, if not more so, around the issues of curiosity, humility, and also human-centered design.
Yeah, that actually perfectly segues into another question that someone had. They're asking, Sophie, if you could talk more about building mindsets of cultural humility and curiosity among safety net leaders, what challenges do you encounter in that work?
I mean, start off with myself. I have to always remember to be humble and curious. And so it's for all of us. We can all work on that. I think that's the first piece. But if you look at leaders in the safety net today, what is one of their main challenges? It's retention. The workforce challenges we're facing are huge. So recognizing that, I think, is an opening to work with the leadership of building humility and curiosity. Really lean into the biggest challenges. And what we hear from many of the frontline staff is they want to serve their community better. They want to feel empowered to change the way of working to serve their community better. So the examples we have seen where frontline staff are given the time to do interviews and take input from the community and then really be empowered to make changes based on the feedback, that helps retention. So if you can engage the leadership to see that opportunity, that it's actually this work using, for example, human-centered design helps retention of your workforce and helps you serve your community better, then you build that muscle of humility and curiosity. Very often, if you define a problem with the community and bring it to the leadership, very often it sparks curiosity. You want to find out more. But if you package it within how it actually is going to support also retention of your workforce, I think you're more likely to be successful.
And if I can add to that, Sophie, I think continuing to be self-aware around who is making those decisions on a day-to-day basis, it is us or simply people in leadership, then that is a challenge in itself. I know when we're talking to Mike, it's specifically thinking about how we can be more community driven, how we can have the community be in positions of power and make decisions. And Mike, you're talking a bit about your board makeup. Can you talk a little bit about what that structure looks like?
So with federally qualified health centers, it's actually a requirement to have patients on your board of directors. And that's something that we take to heart in our Asian Health Services. And not only do we have patients on our board members, but we have different advisory groups, including what we call patient leadership councils. And we have 7 different patient leadership councils, which are done in language. That's Chinese, Mandarin, Vietnamese, Korean, Tagalog, Burmese, and I can't remember the last one. But the point is to be able to really get direct feedback from the community and not just tell us what we want to hear, but really tell us about what their needs are. And when I occasionally get a chance to interface with patients in my broken Cantonese, I know enough to be able to hear, what are some of the things that they're going through. And they'll mention not just things related to patient care, but they mention sort of some of the needs right now that they're facing, including, right now, just with some of the increased tension in Asian communities about feeling not safe to leave their houses. But I think that it's definitely important to get that feedback. And during this time, where a lot of us have had to transition to Zoom or other ways, we've still been able to do that, get that patient feedback. It's been harder because our strength has always been the face-to-face, the interfacing with folks at parks, at face-to-face meetings, going to the cultural festivals, in and around the community. But, we tried our best to still be able to get an idea on the pulse of the communities and what their greatest needs are. I wouldn't say it's perfect. I don't think anything can really replace the face-to-face interactions that going door to door, so to speak, but we're trying.
Thank you, Mike. One of the things that I've admired about a lot of your organizations is how you have used your organizations as a platform for the community. And I think a lot of our roles is in amplifying the challenges that we're seeing, not making decisions unilaterally, but how we can be promoting more of the causes and the care abouts of the people that we're trying to serve. So I see another couple of Q&A. I think we have time for one more. This one might be a tough one. So the question is, with staffing challenges born out of the pandemic, how might safety net clinics rethink how they manage patient health information in an era of health information exchange, population health management, social determinants of health, etc.? So this is in the context of the traditional medical record management office.
I have to admit, this is not an area that I feel very able to comment on because it's in a level of operational, the questions are very operational. So for me, it's a hard one to answer. I will say that we are focused on really, I think, again, the pandemic forced an injection of having to leapfrog quickly to newer, better, more efficient systems. So I think we are doing a lot more training. We're investing. Partly the retention issue, trying to really help our staff that are, as you said, stressed out and retention is a huge issue. Doing everything we can to give them the tools they need from the provider level down to be collecting that. So sometimes that means investing more staff in, for example, more medical scribes. On the other hand, it also means making sure that the staff that are dealing with some of these systems are better trained. I don't think that's quite what the questioner was, getting to, but that is something I know that we are doing. I also would say that, again, in the macro sense, another thing we are doing related to this data is bringing it, collecting it. I mean, Epic was one change we made, but we're also working together in a Tableau system, which is an even greater input of collection of data and then sharing it in much more real time in our system. Again, that's not quite what the questioner, I believe, is asking, but that's just an element of it that I can comment on.
I appreciate that. Sophie, did you have something to chime in?
Yeah, I can try. This is hard. It's also framed very technical, far more technical than I normally operate at. as we talked about earlier, there's more and more data, and we have more and more systems and different forms of applications feeding that data. And then, as the person is saying, this is in the context of a traditional medical record management office. I think it's important to recognize we don't need to do everything in-house. There are many of our partners are for example, their remote patient monitoring work, partnering with organizations that also come with the analytics. You don't need to feel that you need to do it all in-house. And then over time, you can figure out what you may want to insource. But there are partners and it's important to do the legwork to know where is their interoperability with the systems that you have, to not build additional legacy systems that will be hard in the future. But we've seen that work really successfully. There are vendors that, and especially if you can start to actually do some work where you share the upside, you're paying them based on improved outcomes. You get more payment from the health plan because you're improving the blood pressure control together with this vendor, and they bring the analytics. So they're being creative in how you work with partners can actually help also on the side of managing the information systems.
I'd like to add one more thing that I did forget about that may be pertinent, which is Lifelong has implemented a sort of data governance committee that was brought together by a newly created position. We have a chief, I think it's medical information technology officer. She's a nurse practitioner, but really it's about data transparency and data governance. And that is one way I think when you're talking about managing patient health information, making it more transparent to everyone that needs to see it, and also in much more real time so that we can influence better health outcomes. That might be a good topic for another conversation, because that's an initiative I would say that I know our CEO is extremely proud of.
Yeah, absolutely. And this may also relate to one of the first questions that the audience asked: how can private sector players play a role? This may be an opportunity to really recognize what is your superpowers and how you can elevate a lot of the community health centers and the work that they're doing as well. So I know we are coming up on time. We did have a question that we didn't get to, but we can probably circle back around with that and share the answer with the rest of this group. So final question for each of the panelists: what advice do you have for people working towards addressing health equity? Mike, would you like to start?
I'm pretty sure that hopefully a takeaway that you all watching have heard is about the importance of data and the right type of data. I'll just say is also, this will be my plug for disaggregated data. Just knowing that the data points that are out there, really needing to dig to the level, either a community level or by some other, demographics, to be able to really, dig deep on the most underserved communities. And, I think is, actually goes back to the last question, but even less the data that we collect, but also, at times we've tried to push for, state and federal policymakers to increase, sort of the data points that they collect, and that can make things a little bit easier on everybody. But just I'd say is right now, it's definitely important to get more data. And I mean that to being still finding a way to, connect with people, and, we're still doing that. We're doing some of them, getting some of our patients on Zoom meetings, or also just calling patients. We're finding even just when we call, you folks have to do short, just reminder calls for appointments. They end up being 20 minutes because the patients have a lot of stuff they want to share. But this is all stuff that we need to hear, and we need to be, out there, so to speak. And just saying, get out there, and in the community. And that will help illuminate where we need to do more as far as improving equity.
Thanks, Mike. And I really love the encouragement to really engage with the community. Sylvia, what final advice do you have?
Well, it's impossible to, I think, separate out health equity from equity writ large. And again, bringing it to sometimes another current example, I think about, there's been a lot of discussion I've been hearing lately about, obviously climate change is a big issue, and the notion between individual action and systemic change. And so when I put health equity into the context of equity writ large, I think an important piece of advice I have is not to forget about the advocacy component and the component of collective action. We all may be doing this in a different way. Somebody may be like, on the health center floor with patients dealing with our, health record system. And I'm doing broad communications and fundraising, for example, but we're driving toward the same conclusion of quality healthcare for all. And I think that not forgetting about the need to put it into a collective action and advocacy context and taking whatever actions we can, as an individual, of course, but even within our organizations, whatever we're allowed to do. And that is an important part of what FQHCs do. And it is really at the heart of my career. I've been mission driven from my first job on, and I've been involved in advocacy for most of my career one way or another. So that's the piece of advice I would give.
Thank you, Sylvia. That definitely hits home for me as well. So final advice?
I feel Mike and Sylvia had made fantastic points. I was thinking along the lines, which is our vision around fair, just, and inclusive opportunities to be healthy. Starting off with Mike, we can't be fair if we don't look at the data. And we have to disaggregate and really challenge ourselves of how we identify where is it not fair today. And look outside of the data sets you have yourself, who is not being seen at all, making sure no one is left behind and really aiming for being inclusive. But to be just, data is not enough. We need to do, like Mike said, and Sylvia's point, it's not only within healthcare. Listen deeply to the community to understand where the challenges are and feel empowered by what you hear and create space for people to bring that voice forward. You don't need to, you should use that when you speak to funders, when you speak to leadership, but also create space for others. A week ago, I realized again, I made a mistake. I am the leader of this organization. I'm a white woman sitting on this panel. I could have created an opportunity for someone else, because I think there's more systemic challenges in terms of power dynamics and who is speaking where and when. And many of us can do far more at an individual level to challenge ourselves of how we create opportunities for others. We don't need to speak on behalf of others. We can actually give the floor and lift others in other ways. So constantly challenging ourselves and supporting each other to really disrupt the deeply unjust system that we all work within.
Thanks, Sophie, and specifically for that self-awareness that you bring to your leadership. So, Sophie, Mike, and Sylvia, deep gratitude. Thank you so much for being part of the panel.